After we have heard questions from those in the room, we will then entertain questions from those joining by phone. Please state your name and affiliation before asking your question. I will restate each question before turning it over to the panelists to answer so that the reporters on the phone can hear. Yes, so, sorry, glasses. This gentleman straight ahead. Yes.
Neil Osterwell with Frontline Medical News. Questions for Dr. Armand and Dr. Moskowitz. What about, do we think we might be seeing in the future combinations of checkpoint inhibitors, different targets in melanoma, at least for one drug, but are we going to be seeing that? Are people looking into those?
So the question is, will we be seeing combinations?
Yes, combination of PD-1 inhibitors, different inhibitors.
Combinations of
right.
PD-1 inhibitors being used together.
Right.
I mean, in the near future?
Yeah.
I don't think in the near future. Yeah. I think we're trying to figure out, it's a little, Hodgkin lymphoma is quite different than melanoma, obviously. Mm-hmm. We cure almost all the patients, and these drugs have very high single-agent activity. I personally would like to see how they play in the sandbox with standard treatments before trying to further exploit the immune system.
Yeah, it's going to be my next question, actually.
And it may be that, I think it's not likely that different PD-1 antibodies will be used together, but it's possible that PD-1 antibody will be used with other checkpoint inhibitors that target parallel pathways. There's a study that's ongoing now, actually the follow-up to the study that I was talking about, which combines a PD-1 blocker with a CTLA-4 blocker, which is another checkpoint pathway. Ipilimumab, yes. As was done in melanoma. But it may be, as Dr. Moskowitz was saying, it may be that the answer lies in combining it with standard types of therapy or with immune therapy or both. Time will tell.
Gentleman here.
Hi, I'm Rob Valansky with Hemonc today. Dr. Bollard, if you could just give one or two quick thoughts, just offer some perspective on each of the 4 studies, or a couple of them, or whichever ones you feel are most interesting. I would just like your reaction.
You for this. I told you this was going to happen.
So I think it's very important to emphasize that actually all these are extremely important, and actually I see them all as very synergistic and could be ultimately used together, because ultimately I think our goal is to overcome the use of chemotherapy, radiation, which, as you know, blasts everything healthy and malignant cells. And this way, all the strategies you heard here today are really those to target the tumor cells themselves by using our own immune system to attack the cancer. So it's extremely exciting. The caveat, as you hear, especially with the successes of the CD19 targeted therapies, is when you really rev up the immune response, there is some toxicity associated with that. So ultimately, I think we will have to try and balance how much you can excite the immune system, and whether it's sort of a stepwise fashion rather than just using all the therapies together. But I think it's so exciting because I see it as a way forward to how it will revolutionize the treatment of hematologic cancers. Yes.
Hi, Caroline Helwig, ASCO Post. About the PD-1s, the endocrinopathies has been a concern in melanoma. Do you see, somebody mentioned just a line about them, but can you elaborate? Did you not see any endocrinopathies that do not resolve?
Endocrinopathies with the PD-1
yes.
Well, I think
blockers.
at least for, I'll discuss it at the major presentation, but they have been reported
right.
In other studies, in solid tumor studies,
right.
and they certainly are seen in these studies as well.
Okay.
But they tend to be easy to treat.
They do, because they're long-lasting in the melanoma studies.
Oh, they're probably long-lasting in the hematologic oncology
can
studies
be
as well, but they can be treated.
Okay,
yeah.
and also, did you look at do a genetic analysis the way Dr. Armand did, looking for
I think
that
I think samples are available, but they have not been done yet. Hard to imagine, though, it won't be similar.
Okay, and one more question: are there any other hematologic malignancies that have that same genetic abnormality that might respond to PD-1s?
So one of them, I can answer that if I may. One of the other tumors that is very similar genetically is a subset of diffuse large B-cell lymphoma called primary mediastinal large cell lymphoma, which was included in both of these studies. But the patients, fortunately, are rare because frontline therapy works quite well for this disease. So it's hard to know whether it'll have the same kind of responses. It may not be quite as sensitive as Hodgkin lymphoma. Those are really the only two that we think have this genetic background for PD-1 blockade.
Okay. Sorry, and
Lynn
then
Peterson with Trends in Medicine. So, Dr. Moskowitz, the overall response rate was lower for pembrolizumab than for nivolumab in the brentuximab failures. Can you address that? Was
I just think that
66 versus 87%. I mean, that's a substantial difference.
I actually think that, in fact, both of us study both drugs. Okay, so it just so happens that these how the presentations are. I see the drugs as very similar, quite frankly. I mean, it's the matter of the patients that you get. It's probably not related to the drug itself. My gut feeling is that at the end of the day, the response rates will be very similar. The complete response rates will be similar. I think that the toxicity profiles may be slightly dissimilar, and we'll have to see what happens when these studies are both peer-reviewed. But I think the results are very similar.
I agree. I think you should be careful to make conclusions on this kind of number of patients. There is still some heterogeneity in the patients or in their tumors, or possibly biological heterogeneity. And if you compare, you can't compare a response rate of 65 and 87% and really conclude that the drugs are different. It could be at the end of the day, but I don't think we can conclude that from the current crop of studies.
Okay, question down here.
Yeah, Michael Smith, MedPage Today. This is a question for the non-PD folks. Dr. Gökbuget, I wonder, you have an odd kind of, this is a whole new endpoint for me. I've never heard of it before. And I didn't really quite follow your explanation of what an MDR complete response was. So my take was that people with MDR have a small amount of residual disease, and you somehow are knocking that down completely, or knocking it down to undetectability, or what?
So the question is regarding the MRD endpoints for the blinatumomab study.
Okay, it's about MRD, and MRD means that the blast count is no longer detectable by conventional methods, which is microscopy of the bone marrow smear. So the blast count is in the beginning of the treatment already below 5%. And still it can be quantified by these PCR-based technologies. You can exactly say this patient starts the treatment with, for example, 0.1% or 0.2% or whatever. And of course, in these patients, you need also a new response classification because the conventional classification doesn't work anymore. So this is the MRD-based response evaluation, meaning that it is just a lower sensitivity level. So MRD response means then that with a sensitivity of 10 to the -4, you cannot detect any blast cells anymore. So you just put down the sensitivity from the 5%, which is cytology, to 0.01%, which is for MRD evaluation. It's just another cut point for sensitivity. But still you measure in a quantified way the tumor load. No?
How many zeros in that?
0.01% is the sensitivity. So you can detect with this method one blast in 10,000 normal cells.
Okay, so this gentleman there, and then this gentleman in the back there.
Peter Droppert, Biotech Strategy blog for Dr. Grupp. Very impressive data from my point of view, and I remember you from here last year's data as well, so great to see this continuing. Could you tell me a little bit about what your thoughts are on what causes the cytokine release syndrome? Is this something that we're going to be able to engineer CARTs to deal with? Because we're seeing this across all of the CART in development? And also, could you share a little bit of commentary on the different? Is there any differences between pediatric data and the adult data? Because obviously, data at this meeting for CTL019 with the adult ALL data with patient deaths, is the immune system of children different, or is it the same? What we're seeing between the two. Thanks for your thoughts on all of that.
So the question for the reporters on the phone is related to the cytokine release syndrome we're seeing with the CD19 CAR T cells.
So I think that the cytokine release syndrome is an important toxicity. As I've shown you, it is very much related to how much disease the patients have. The key to the cytokine release syndrome, and I believe this carries across platforms and actually may also apply to blinatumomab, is the amplification of the macrophage system through interleukin-6. This is a classical feedback loop that is actually druggable, and so we target it in these patients using tocilizumab, which is an IL-6 receptor blocker, and that has remarkable control of the cytokine release syndrome toxicity. So all of those severe patients that I showed you had gotten tocilizumab and experienced within hours in many cases, but within 2 or 3 days in all cases, resolution of their cytokine release syndrome. So in the absence of this IL-6 pathway control opportunity, I think that the toxicities would be quite daunting. As far as the differences between an adult and pediatric data, I think that there are presentations at ASH for some limited, there's some limited data available in the adult ALL population. However, we started in pediatric ALL before the adults did, and they have far fewer patients. So I think it's way too early to be able to say what the differences are in terms of the efficacy or the potential toxicity. As an example, in the New England Journal paper where we had 25 kids and 5 adults, the first 5 adults all went into remission, so there was a 100% CR rate. Is that different from 88 or 92? Hard to say. So I think the answer is that we need a lot more experience in both populations to be able to make any kind of comparative statements. Cytokine release syndrome exists in both populations and is very much related to disease burden in both populations.
Hi, Ed Sussman with MedPage Today for Dr. Armand. Have you calculated the median duration of response in your patients?
So this is regarding the PD-1 blocker,
Yeah.
the nivolumab, and the median duration of response.
So we have, technically the median duration response is 52 weeks, but this number is a little bit misleading because most of the patients, as you can see, have ongoing responses, and so they get censored early. So at this point, it's too early to really get a sense of it. We know that there are durable responses, and one of the patients who is on the graph that I showed stopped the drug for toxicity. So stopped the drug, was in complete remission at the time, and at the time of the data lock was 16 weeks out and was still in complete remission without any further treatment. So one of the questions which we now have to address is when you get patients in remission with these drugs, how long do they last, and can you stop the drug at some point?
And I had one other question on that same graph showing the patient response. You had one patient that looked like did very much worse than everyone else. Have you looked at those patients who didn't respond to find out if there's something different about them?
So there are patients who progressed on treatment on this study. We don't have yet any sense of why that is. One of the most interesting ways to answer that question would be to have tumor material from the time of relapse so that you can see, does it change and how does it escape PD-1 blockade? We don't have any of that information now, and it's unfortunately, those samples are hard to come by, but with larger studies and more patients, we hope to be able to answer that, because that's an excellent question.
Nick Mulcahy from Medscape. Question for Dr. Bollard. Do you look forward to the day when you'll be installing a CAR T-cell unit at your center and treating patients? And is such a notion possible, Dr. Grupp? Is some way to to manufacture this and kind of scale it out to other centers, or is it going to be just at a few isolated places?
So
And what would be the time frame for something like that?
So is this a question for
Yes,
me
it's
or
for
Dr.
you and then
Grupp?
Dr. Grupp.
Okay. So, this I think is the field of cell therapy, I think is, what model do we follow? Do we follow the pharma model or do we follow the HSCT, BMT model? And so I think one very exciting thing about the CAR T cell therapy field is that there has been so much interest from pharma, and with that, then I think we will start seeing these more centralized manufacturing models where they centrally manufacture the product and ship them out to the various centers. And I know Dr. Grupp will talk to you about the phase 2 study, which is planned, which will be very important multi-center study to show that that model is totally feasible. So not all cell therapeutic strategies are maybe going to fit that model, but you're right, it could, I think that's the model that could, provided that pharma remains invested in this, that will be the one to broaden applicability in the shortest time frame.
So, of course, I agree with everything Kath has said. So I think the two key questions here are toxicity and logistics. We've talked about toxicity already. Logistics is, are we going to be actually able to develop these personalized products for every patient? So Novartis has licensed this therapy. They have built a cell manufacturing facility. There is a multi-site pediatric phase 2 trial that actually is in progress and is enrolling patients at multiple pediatric centers. So the eventual rollout will be to 8 or 9 pediatric centers. And so that's open now. Patients have already been treated on that study, both at Children's Hospital of Philadelphia as the initial site, but at other sites as well. So that's happening now. And so we will test our ability to both use this therapy in other pediatric hospitals and with an adult study to follow. And I think very importantly to understand this key question of logistics. Can we collect a cell sample? Can we send it to a centralized manufacturing facility? Can we send it back? And that's, of course, the process we've used at CHOP because Penn has made our cells, and so we've already had to do that. But now we're doing it across the country, multiple sites from the West Coast to the East Coast.
Janine Budding, Netherlands. I have a question about the CAR study. Dr. Grupp, can you tell a little bit more about the population? Did you see any differences between boys and girls or any racial differences?
So the answer to your question is we didn't really see any gender disparities in terms of response, and also we didn't have enough patients to really make any statement about genetic differences, as you know very well. There are racial differences in terms of response to upfront ALL therapy, and especially the Hispanic population is overrepresented in the relapsed ALL population. But in 39 patients, we really aren't in a position to be able to sort that out. It's a great question. What I hope is that the genetic characteristics of ALL that lead to a poor response aren't of interest to the CAR T cells that are just attacking the surface molecule. I don't have data to answer your question, so I have seen no signal whatsoever that suggests to me that there are going to be differences.
Yes, this gentleman down here.
Neil Canavan, Pharma Times. For Dr. Grupp, this is a follow-up to comments that have already happened. As far as logistics, your feeling about the possibility of allogeneic CARs, and as far as toxicity, there was a lot of talk after the Juno incident about a kill switch. Or is that still being considered?
So there are several questions in that. So the first question is allogeneic CARs. So there are two possibilities here. One is that you would truly use an allogeneic CAR, which is in a patient who's undergone a transplant, go back to their donor and collect T cells from that patient. Or the more exciting notion is that you might actually take third-party cells, engineer out the possibility for alloreactivity, and then give those cells back. If that's possible, then we have one donor to many patients instead of one donor to one patient. So that would be very exciting. There's no data yet to show that that's going to work, but people are working on that. I think it's very exciting. From our standpoint, the way we've approached the allogenicity question is we've had 2/3 of our patients already had a transplant. we collect their cells. Those cells are of donor origin. The median donor chimerism in these patients in the T cell compartment is 100%. So we know that we can collect those cells, we can activate them, we can give them back, and we don't see any GVHD. So we've really focused on using allo cells from the recipient of the transplant and not from the donor. As far as the kill switch, that's a very important technology. People are looking at that, but the CAR development program at Penn has not focused on that particular aspect at this time.
Okay, we'll take one more question from the floor, and then we will do the phone, right? Yes, this one.
Yeah, Peter Dropper, Biotech Strategy blog for Dr. Grupp again. Just following on with questioning there, in terms of the future for CAR T cells, you're adopting approach. This isn't a bridge to transplant. Could you talk a little bit about that? Does that mean where WIS could be a replacement for transplant in the future, more frontline? Is that the vision in ALL and where you see it going? And if so, what the steps we need to do before we go there?
Yeah, that's a great question. So I am a bone marrow transplanter by trade. I see how successful and unsuccessful bone marrow transplant is for ALL. I would love it if this technology would replace bone marrow transplant. Whether or not that's possible, I think the fact that we're seeing longer-term disease control in some of these patients and that these families have had the willingness to make a decision, which is entirely up to them, whether to proceed with transplant or not, and allowed us to understand what the characteristics are of long-term disease control. I think that for the first time, we're beginning to see what it might look like to be able to ask that question. So in the future, could I imagine instead of this being a bridge to transplant, it's a replacement? That would be my fondest hope. We're not quite there yet, but we're a lot closer than we used to be.
Okay, thank you very much. Now we would like to open up the phone lines for questions. Is there the operator who can ask if there are any questions from our listeners?
Thank you. If you have a question on the phone line, please press star then one. Okay, if there are no questions on the phone line, please continue.
Are there any more questions from the floor? One more question from the floor.
So this is Lynn Peterson from Trends in Medicine. Dr. Grupp, you had 10 relapses, and can you tell us about those patients?
Yeah, so I think we were recognizing two patterns of relapse in these patients. So most of the patients hang on to their CARs for a long time, but patients who lose their CARs within about 2 to 3 months are at higher risk for CD19 positive relapse, and we've actually successfully retreated a few of those patients. So that's one pattern that we've seen. The other pattern is patients who've had longer-term CAR persistence, but then recur with CD19 negative disease, and we've seen that in a handful of patients. And some of those patients had been exposed to another CD19-directed therapy, which is blinatumomab. I don't know if there's any connection there at all, but of course it's been seen in blinatumomab as well. Blinatumomab. But I don't know if there's far too few patients to really say anything on that. But what we're seeing is the T cells are killing all the CD19 negative cells, but there are a few CD19 positive cells, but there are a few CD19 negative cells that form the basis for a relapse. And so that is definitely something that hasn't happened in a lot of patients. We've definitely seen it.
Okay, so that concludes this press conference. Thank you for everybody for your participation today.